today, chapter 13, we're going to go through the peripheral nervous system, and as I have said, the peripheral nervous system, or PNS, cannot really be separated from the central nervous system. So we're going to look at how input gets into the central nervous system, and we'll just touch a little bit on how response comes out of the central nervous system, mostly because we've seen that before in chapter 9, looking at neuromuscular junction. So by definition, the peripheral nervous system are all of the structures outside of the brain and spinal cord. Right? So the main things that we're going to look at are the nerves, the peripheral nerves. We also have to talk a little bit about sensory receptors. Right? So what kinds of structures are going to allow us to receive signals? That's what a receptor does. We roughly break the peripheral nervous system down into two parts: the incoming information, the sensory division, and then the outgoing information, the motor division. And we covered this in chapter 11 pretty in depth. Now, those sensory receptors, there are various kinds of sensory receptors. What sensory receptors are going to do? These are going to experience some sort of stimuli. They will then undergo a depolarization, and that's going to start and kick off action potentials in sensory neurons. Okay. Those sensory neurons transmit the information to the brain. Brain is where you become actually aware of the sensation. Okay. This is where you have the level of awareness, perception, sensation. Okay. And that's all going to be occurring in the various regions of the cerebral cortex, which we discussed in chapter 12. Now, the types of receptors that we may have in the body are going to respond to different types of initial stimuli. So if you can think about how the things that we can respond to, one of the first kinds of receptors we talk about are mechanoreceptors. These mechanoreceptors, these are going to be responsive to mechanical stretching, pushing, pulling, pressure, vibration. Okay. These we have seen examples of before. Okay. The things like the Pacinian corpuscles are actually a type of mechanoreceptor. Interesting enough, we won't get into it in this class, but hearing, our sense of hearing, or our auditory sense, is actually mechanoreception, sensing the waves created in the air when an individual speaks. Okay. We also have thermoreceptors, and thermoreceptors would be sensitive to changes in temperature. Right. These would be, we're going to see that these are going to be important both externally and internally to monitor both our external exposure to temperature and our internal body temperature. Photoreceptors respond to photons of light. Okay, so these are very important, especially the cells within the retina. This is what, when we see vision, okay, really is a response to light. Okay. Then we have chemoreceptors, which are responding to chemicals. The two most obvious that we would experience in terms of chemoreception would be taste, right, gustation, and smell, or olfaction. In both of those, we're responding to chemicals that are either dissolved in a fluid called tastants, or dissolved in air, which then dissolves in mucus, and those are called odorants, whether we're talking about gustation or olfaction. Chemoreception is also going to be really important internally in terms of sensing changes in blood chemistry, in terms of sensing changes of what's going on in our body. The final category are the hardest to define, and this is called nociception. These are where you have things that are sensitive to pain-causing stimuli, stimuli that are potentially damaging to your body, usually lead to nociception. Okay. Certain things that nociception can actually be different types of stimuli, right? So you can imagine if you have a small abrasion on your skin and you rub alcohol on it. Ouchies, right? Alcohol is actually damaging to the skin. Okay? We use it to clean wounds if we don't like the person whose wound we're cleaning because it hurts, but it is effective. However, it is potentially damaging, so your body responds to it with a pain stimuli. So in that case, it is a chemical, it is the alcohol, but it is giving a pain signal, which is called a nociception. So we can classify these receptors by what they are responding to. Okay. We can also classify them by where they are in the body. Right? So most of the ones that you guys probably think of are what are called exteroceptors. Okay, these are receptors that are on the external portions of the body, and they sense what's going on externally. These are things that you'd find near the surface of the body. These are going to be sensitive to touch, pressure, pain, temperature. Okay. We have seen some examples of these in the skin when we looked at the integumentary system and we saw the Pacinian corpuscles, the Meissner's corpuscles. Those are all exteroceptors. Okay. What we have outside that is going to be sensitive to changes in temperature, right? This is where the body is able to respond to an ever-changing external environment. We also have interoceptors. Okay. Interoceptors, these are found within the viscera, right, so within the organs. These are going to be very sensitive to chemical changes, stretch, temperature changes. Okay. We are not usually aware of these unless one of these becomes problematic. So most of us probably are not exactly aware of how stretched our bowels are right now, right? Our large intestine. Okay. But if there was some problem going on, you might become very aware of it. Okay. Temperature changes, very important. We are what's called homeothermic, right? So we maintain our body temperature in an external changing temperature. We have to be very careful. Okay? Our body has to maintain that proper range of normal body temperature. The third kind are what are called proprioceptors. Okay. We've looked at these. We looked at these briefly in Chapter 8 when we looked at the joints. These are going to be important in telling your body where it is positioned relative to other body parts and relative to space. So we will see that there will be stretch receptors that are found within skeletal muscles, within tendons, within joint capsules, within connective tissue. This is what's going to give important information on this, really another sense called proprioception. That information goes up to the cerebellum so that the cerebellum can communicate with the cerebral cortex and the premotor and primary motor cortices in order to determine how to best complete a movement. Okay. It's this proprioception that allows us to move in a smooth, coordinated, balanced way. So those are two of the ways to classify receptors. The last way is with how complex they are structurally. Okay, so we can have something that's called unencapsulated versus encapsulated. When you have an encapsulated, you have a receptor that is separate from the neuron. You have a receptor that has a complex structure. As opposed to if you have unencapsulated, you usually have free nerve endings, or you have a very simple cell communicating with a free nerve ending. Right? So this receptor type chart kind of reviews the structural class. Right? So whether they are unencapsulated or later on we'll see encapsulated, gives you a diagram of them, lists the functional class depending on location, extero, intero, or proprioceptors, the stimulus to which they are sensitive, and where you would find them in the body. And we've actually seen some of these before. Okay. Remember when we looked at the integumentary system, we actually saw 3 of these. These are all unencapsulated. We have free nerve endings. We have Merkel cells or Merkel discs. And then we have the hair follicle receptors, right, where we basically have neurons that are interacting either in the epidermis with the Merkel cells in the epidermis or in the dermis wrapped around the hair shaft. Right. These would all be, for the most part, exteroceptors. Right. We do have some of these free nerve endings. These are the most general kinds. We have lots and lots and lots of different free nerve endings in lots and lots of different places. So they can be other things as well. And these are going to give you some examples of what they respond to. So mechanoreceptors sense movement. If we think back to this example of the neurons wrapped around the hair shaft, when that hair shaft moves, those free neurons, those nerve endings, become stimulated. That's mechanoreception. Okay. So these would be exteroceptors. Obviously, hopefully you don't have hair inside of your body anywhere. The more complex ones are the encapsulated ones. We've seen these first two before. We have the Meissner's corpuscles and then the Pacinian corpuscles. Okay. These again were found within this would be in the papillary layer of the dermis. This was deeper down in the dermis. These are, for the most part, exteroceptors, though we can actually see these Pacinian corpuscles in other places other than in the dermis. The last ones are going to be very important. These are encapsulated as well. These three are going to be very important in both exteroceptors and proprioception. So we have these things called Ruffini endings. These would be within joint capsules. Thank you, joint capsules. My brain just stopped for a second. Joint capsules. Over here, these intrafusal fibers, these are also called muscle spindles. These are actually within a muscle and they sense the stretch of the muscle themselves. We can also then see these Golgi tendon organs or these joint kinesthetic receptors, and these are going to sense the stretch of a joint by looking at how stretched the tendon is or the joint capsule is. Okay. So these three will function together in proprioception. They're sensing stretch, and that's going to be really, really, really important. We'll actually look at an example of that when we talk about reflexes. Now, this does not include the special senses. Okay, we're not covering the special senses in this chapter, right? But the special senses would be specialized cells that allow for olfaction, for gustation, for vision, right? And for auditory sense. Any questions on those receptor types? Now, simply receiving information is all well and good, but in order for you to respond to it, we have to become aware of it. So you have to be able to actually have sensation and perception of that stimulus. Okay. This is going to require higher regions. Okay, for you to become aware of things is where we're going to have to move into talking about the brain and some of the brain regions, and that's connecting chapters 13 and chapters 12. There are three main regions if we're talking about the somatosensory system here. We have our receptor level. Receptor level is what we were just looking at. Here we have these different receptors. We have our free nerve endings, we have our muscle spindles, we have our joint kinesthetic receptors. Three examples. This is where the usually mechanoreceptive signal is first received, some sort of stretch, pressure, vibration. Okay. Those neurons then create circuits, okay, and those circuits carry the signal up and into the appropriate lower brain regions. Okay. So for some of the information may go through the cerebellum, some may go through just the pons, some may go then, they will all go through the thalamus. This is all of the circuit level. Okay. You do not have conscious awareness at this point. Okay. You only have conscious awareness of things once they hit the cerebral cortex. So when these signals come in and they get routed into the thalamus then routes them into the primary somatosensory cortex. That's the perceptual level. Right. Now please understand, even though this diagram shows the neurons kind of just stopping there, they don't stop there. Okay. Simply coming into the primary somatosensory cortex does not allow us to become fully aware of what something is. We then need to have the association cortices put that information together, integrate it, make associations for us to become fully aware of it. So we have receptor level, which is just the receptors. The circuit level, that would be our ascending pathways, and then our perceptual level, that would be where we have the neuronal circuits in our cerebral cortex. Right? You want to make sure you are clear on those three different levels of integration. Now what brings these signals in would be the nerve. To quickly review the structure of the nerve, because we're now going to start talking about some specific nerves. Nerve and neuron are not interchangeable terms. A nerve is a bundle of neurons, specifically a bundle of axons of neurons. The nerve has a similar organization to what we saw in muscle, specifically skeletal muscle. So we will have individual axons covered by myelin sheath, each of those surrounded with a very delicate connective tissue called endoneurium. Many of those axons may be bound together in a bundle called a fascicle. That fascicle is then bound by perineurium. An individual nerve may be made of several fascicles. Try this again. An individual nerve may be made of several fascicles held in place along with some blood supply, right, some blood vessels surrounded and bordered by epineurium. Now, in terms of the axons, in a single axon, a signal only goes one way. Okay, so a signal is only going to be going sensory into the brain, afferent, or motor, response, effector, out of the brain to the body, okay, in an axon. But within a nerve, we may see that some axons go one way, some axons go the other way. When we look at the classification of nerves, we have a few nerves, and we will talk about these, that are purely sensory. Okay, so these only carry impulses to the central nervous system, so that means that all of the neurons within that nerve are sensory neurons. Okay? We'll actually look at two examples of that when we look at the brain and what are called the cranial nerves. We also have motor nerves, right? And motor nerves are only motor, so they only have neurons that carry impulses from the central nervous system. Okay? And we will see one example of that that you'll have to know in the cranial nerves. Most of the nerves that we will talk about, the spinal nerves, are going to be mixed. What that means is within the bundle of the nerve, some axons are sensory and some axons are motor, and they bundle together. They run together. Right. So the first types of nerves we're going to call the cranial nerves. We'll see 12 pairs of cranial nerves. These 12 cranial nerves come directly off the brain. Okay? They do not have interaction with the spinal cord. These 12 pairs of cranial nerves are the same on the left and right half. If you start towards, we are looking at a posterior view, so we're looking kind of up at the brain. If you get your orientation, okay. This first largest, that's very clear cranial nerve, that is the olfactory nerve. The olfactory nerve has a kind of rounded out region here that's called the olfactory bulb. And then there's this region here that's called the olfactory tract. Please remember the difference between tract and nerve. A tract is where you have a bundle of axons within the central nervous system. A nerve is where you have a bundle of axons within the peripheral nervous system. So I'm saying this is a cranial nerve, but then I'm calling it a tract. Okay? It's one of these kind of arguments because the olfactory nerve is so tightly associated with the brain that it's sometimes considered that this region here is not actually a nerve, but rather it's a tract because it's not really, you can't really separate it from the brain. As far as testing goes, if you were to refer to this as the olfactory bulb, the olfactory tract, the olfactory nerve, testing-wise, that would be fine. Okay. The next one then is the optic. Okay. These are all also numbered with Roman numerals. Okay. So this would be Roman numeral 2, which is II. Okay. Here we have the optic nerve. The optic nerve goes out to the eye, so you can imagine that one would go out to an eye, this would go out to the other eye. The cross here is called the chiasma, and then the nerve becomes the tract and passes back into the brain and eventually heads over to the primary visual cortex in the base of the occipital lobe. Just behind this then, we have number 3, which is the oculomotor nerve. Now, 1, 2, and 3 will be the ones that I will be testing you on in terms of their function, where they're located, what they do, finding them on the brain, so on and so forth. Now, I'm not saying that you don't need to know the others, but I won't necessarily explicitly test you on the other 12. Okay? But we will take a moment now and go through the other 12. Okay? So number 4, with Roman numeral 4, this is the trochlear nerve. 5 here is the trigeminal nerve. 6 is the abducens nerve. 7 is the facial nerve. 8 is the vestibulocochlear nerve. 9 is the glossopharyngeal nerve. 10 is the vagus nerve. 11 is the accessory nerve. And then 12 is the hypoglossal nerve. What these different nerves do, these will be innervating regions of the face, the tongue, the pharynx, the larynx. So these will be responsible for most of the movement and control of this region, the face, neck, throat region. They can be mixed. They can be purely sensory. They can be purely motor. So olfactory and optic are sensory. They do not have any motor function. Okay. So what that means is they only have axons that come in from the nose and eyes respectively, right, and that information is then sent to the brain for processing. Whereas the oculomotor is only motor. Right. Some of the other ones are going to be both sensory and motor. So for example, if you look at 7, 9, and 10, the facial, the glossopharyngeal, and the vagus, those are all going to have a role in taste. They also will have a role in movement of the tongue and throat. Okay. What that means is some of the neurons within that nerve are sensory neurons that are associated with chemoreceptors found on the tongue. Right. Some of the other parts of those same nerves then are motor, and those are associated with the muscles of the tongue. We'll take a closer look at the first 3 cranial nerves, so olfactory nerves. This is how we have our sense of smell. What you are looking at here, this is a kind of odd diagram, but let's get our positioning. This would be the frontal lobe of the cerebral hemisphere. Here we have the olfactory tract and the olfactory bulb. Notice how tight the association is, hence that kind of disagreement between olfactory nerve versus olfactory tract. Right. Now here we're seeing bone. Right. This is actually the ethmoid bone. If you remember, the ethmoid bone forms the roof of the nasal cavity. It has within it that cribriform plate that had those very delicate, tiny little holes that were called foramina. Passing through those holes, we would have these filaments of the olfactory nerve. Those actually pass down into the region where the ethmoid bone is. This is the nasal mucosae. So this nasal mucosae, this would be the part of the epithelial tissue that lines the nasal cavity where we have mucus. Okay. When you smell something, smell really is chemicals that are dissolved in the air. Those pass into your nasal passageway. Those chemicals, called odorants, are going to dissolve in the mucus of the nasal mucosae. They will induce chemical changes here within the olfactory tract in these filaments. Okay. These are chemoreceptors. Those chemoreceptors have depolarizations. Those depolarizations send signals. Those signals lead to action potentials. Those action potentials send that signal into the brain. That is how you smell. This is going to be purely sensory. The optic cranial nerve, then, is going to be involved in bringing information from the eyes. Each eye has, in its what's called retina, it has specialized bipolar cells that are sensitive to changes in light. Those send signals. It's a very complex process. There's actually 3 layers of cells that can send signals. Okay. Those signals then pass through the optic nerve. Kind of interesting, in humans, we have forward-facing eyes. And what that allows to happen is some of the information comes in and passes to the left side of the brain from both the right and left eye. We also then have from the right and left eye some going into the right side of the brain, right, passing through part of the thalamus. Remember, all of this information has to pass through the thalamus. Okay, this is what's called the lateral geniculate nucleus. It's one part of the thalamus. What this kind of does is this is what gives us our very clear central vision. It allows us to see with both eyes in the center of our vision. If you wanted to see how this functions, if you were to close either eye, so if you close your left eye, okay, and you bring your left hand from being straight out at your side, bring it forward until it comes into your field of vision, and keep your hand there, then open your left eye, close your right eye, do the same thing with your right arm. Right? We have a field of vision that we can see with both eyes, right? That's where we have our best depth perception, right? If anyone has ever had an eye injury where you lose vision in one eye, your depth perception goes completely. We don't have depth perception in our peripheral vision. This is why when something sneaks up on you or like something comes into your peripheral vision, it's hard for you to tell how far away it is from you. Okay? And that's due to this what's called stereoscopic vision, where we have two eyes using. What that means, though, is we have much less field of vision than something that has their eyes on the outside of their head, like a horse, right? Horses actually don't have very good, they can see very far around, so they can think it's like 280 degrees they can see around their head, but they don't have really good depth perception. And they actually have a blind spot directly in front of their nose, right? So that's why you're never supposed to walk head on to a horse. If you ever go with horses, go from the side. The third one, cranial nerve, Roman numeral 3, is the oculomotor. Okay. This comes off of the midbrain. Now, up until this point, we really haven't talked about much function for the midbrain. One thing that the midbrain does in humans, it is where the oculomotor nerve comes off. It is mainly a motor neuron. Okay. It does have both parasympathetic and somatic functions. So remember, parasympathetic, that is part of the autonomic. We don't voluntarily control it. Okay. This is where we have constriction of the pupil, right? That would occur if you are exposed to bright lights. Your pupil would constrict. We also then have the somatic motor fibers to the eye muscles, and that's what allows us to do voluntary movement of the eye. Okay, so we see all motor here, but actually two different kinds of motor control, voluntary and involuntary motor control. All right, so picking up then with spinal nerves. Okay, if you remember the vertebrae that we had talked about, it will help you. What we have here, we have 31 pairs of nerves. These are all going to be mixed nerves. These originate from the spinal cord. These are going to supply the innervation for the entirety of the body with the exception of the head, and that's because the head is innervated by the cranial nerves. Okay. These are all going to be enclosed within the vertebral column that's made of the vertebrae that we saw previously. The actual spinal cord runs through the vertebral foramen, right, which was the opening that we saw in each vertebra. The spinal nerves then actually come out the spaces in between. We have a total of 8 cervical. How many cervical vertebrae did we have? 7. We have one more nerve pair here than we do have vertebrae, because you can imagine there's one on top. Okay, so if you were to stack 8 things, right, if you stack the 8 nerves, you only need 7 vertebrae in between them. Right? The rest all match up, so we have 12 thoracic spinal nerves, pairs that come off, 5 lumbar, 5 sacral, and 1 coccygeal. Now, down in this lower region, right, we'll see that the nerves are not nearly as clear in the way they're organized. Okay. In terms of the way these come off of the spinal cord, we will see that they have what are called roots. We looked at this briefly when we looked at the spinal cord. The roots are the areas that actually attach to the spinal cord. The roots branch into what are called rootlets. Okay? So the dorsal root is towards the dorsal aspect, right towards the back. The ventral root would be towards the front or the belly. Okay? So if we look at this in situ, this would be the body of the vertebra, okay? Body or the centrum. So this would be where the spinous process would be towards the back. We don't see it. This would be the dorsal root. This would be the ventral root. The ventral root is where the neurons coming from the anterior horn or the ventral horn. This is where we'll have our motor fibers coming out. Okay? In the ventral root, we'll join up, okay? And we're going to look at then the branches that come off. The dorsal root, which is towards the back, this is going to be associated with the dorsal root ganglion. The dorsal root ganglion is where all of the cell bodies for these sensory neurons will be located. Right? So the dorsal root will be sensory. The dorsal and ventral roots join together, and that's where we have the true spinal nerve. The spinal nerve then is mixed. As soon as these come together, they're going to start branching out again. The branches are going to be called singular ramus, plural rami. Okay. So we have roots, They come together briefly, they form the spinal nerve, and then the spinal nerve starts branching. Okay. The branches then are mixed. So the roots are either going to be sensory or motor. They come together, they mix, and then the branches will also be mixed. Okay. The way these branches are named, okay, we have the dorsal ramus. Okay, that's going to go off the back. Okay. We can also then have the ventral ramus, which is going to go towards the front. There's also off the side here, there's something called the sympathetic trunk ganglion. Right? It is a ganglia, so it's a connection of cell bodies. This is what is going to be very important in the sympathetic nervous system, hence the sympathetic trunk. We will take a look at how these spinal nerves branch. Okay. For the most part, the dorsal ramus will go off towards the back and will innervate the back. It will innervate the muscles of the back. It will innervate the areas that are the very important muscles that helps to support the spinal cord through supporting the vertebral column. Now in the thorax region, so we're talking about say T1 through T12 more or less, okay, the ventral ramus that comes off is going to come and is going to sit along the intercostal muscle, right? So between each rib, intercostal. So we call it the intercostal nerve. This is going to innervate those muscles, and those muscles are what allow us to breathe, right? Expand and collapse the chest cavity. This intercostal nerve may branch, and where it branches, it may change names. Okay. So here we see a branch. It's going to branch out. It's going to go below the skin on the side of the body, so it's lateral, so we call that the lateral cutaneous. It continues, branches towards the front for the anterior cutaneous. This is very common in nerves. We have a nerve, it goes, it branches. When it branches, it changes names. Okay. If any of you are familiar with the Altoona region, right, you have Pleasant Valley Boulevard, and at some point it branches and it becomes Pleasant Valley Boulevard and Valley View Boulevard, right, and then it comes back together, something like that. Okay. So it's not that you're changing the nerve. It's not that the nerve is different. It's just going to a different place, so it's named by where it winds up. Okay. That would be in the thoracic region. Now in the cervical region, in the very, very top of the thoracic end of the cervical, the lumbar region, the sacral region, we're going to see a very different organization. Right? If you think about it, there's not a whole lot going on here, especially in terms of motor. What we will see in all the other regions, all of the ventral rami that comes towards the front, except for those from T2 through T12, are going to form what are called nerve plexes. Okay? A plexus is where you have things coming together and then branching apart. Right? We're going to see there are 4 main regions where we have nerve plexes: cervical, brachial, lumbar, and sacral. And what we're going to have is we're going to have fibers from several different spinal nerves that fuse together and then separate out again. Okay. This is important because what this does is each of your skeletal muscles then is actually receiving axons that come from different spinal nerves. It's a redundancy. That's important because if you damage one segment of your spinal cord, it will not completely paralyze that muscle. So if we take a look at this, the first of the plexes we're going to talk about is the cervical plexus. Right? There were 8 cervical nerves. We're really talking about the first 5 that are in this upper region of the neck. Okay. So we name these C1, C2, C3, C4, C5. Okay, we're looking at the ventral rami that come off. These are going to come off and branch and join up and branch and join up and branch and join up and branch until they create these massive nerves that are going to go down and have different roles throughout the ear, the back of the head, the shoulders, the neck. Okay. A very important one here boxed in red is the phrenic nerve. The phrenic nerve is the major motor and sensory nerve of the diaphragm. Right? So if you remember, the diaphragm is a thin muscle wall that sits just below the thoracic cavity, separates the thoracic from the abdominal cavity, and is actually important in its contraction in allowing breathing to occur. So that is a very important nerve. That is the phrenic nerve, and it comes from these first 5 vertebrae. Right? This is why if you have somebody who has damage in this higher region here, right? Complete damage to the spinal cord, they may lose the ability to breathe. Okay. The next is the brachial plexus. The brachial plexus is the remaining cervical spinal nerves and the first thoracic, T1. There's a little bit of C4 and a little bit of T2 that can play a role as well. Once again, we have the dorsal ramus comes off. They join together, branch. This is going to create a bundle, right, that will lead to the different nerves that are going to innervate the upper limb. If we take a look at these, we can kind of see this organization where if we look at this just separately, now these are going to be called roots, trunks. And then we have what's called the anterior and the posterior division. Here it looks flat, but remember, we're a three-dimensional object. So some of those nerves are going to go towards the front, that would be the anterior division. Some are going to go towards the back of the shoulder, which would be the posterior division. Okay, so if you imagine the arm, the upper arm, the forearm, they're three-dimensional. So we have nerves that run the top and nerves that run the bottom. Two of the important ones are the ulnar and the radial. Okay. The ulnar is going to run along the region here. It is going to innervate the last two fingers, okay, so the pinky and the ring finger. The ulnar nerve, I chatted with some students about this previously. The ulnar nerve is what's responsible for the funny bone sensation you get if you bang your elbow, because the ulnar nerve is actually exposed where the ulna interacts with the humerus in the elbow joint. So if you bang your elbow, the quote-unquote funny bone, you're actually hitting the ulnar nerve. Okay. The radial nerve is going to run along the radius. That is going to be important in your extensor muscles. Okay, so that is what's going to allow you to be able to extend the joint, extend your arm. Okay. Another one that's interesting is the median nerve. Okay, the median nerve is going to innervate these three fingers. So if you've ever had your hands go numb, usually you have either these, your thumb, your first finger, and your middle finger go numb, or you have your pinky and your ring finger go numb. It's because they're innervated by two very different nerves. So those would be the ulnar and the radial, coming off the brachial plexus. Then we skip T2 through T12, because there we have the ventral rami, make those intercostal nerves. Okay. Finally, then we move down to the lumbar plexus. The lumbar plexus would be L1 through L4. This is going to innervate the thigh, the abdominal wall, right, and some of the part of the upper leg. Here we have L1, L2, L3, L4, L5. Again, notice the branches come off, they join together, they branch, they come off, they join together. Okay. Two main nerves that come off that you will need to know. One is called the femoral, right? And the femoral has a good degree of branching, and there's actually a branch of the femoral. That goes all the way down to the foot. The other is called the obturator, and that word should sound familiar to you. The obturator passes down through the obturator foramen. Okay. That was in the os coxae, that round opening. That is the obturator foramen, where the obturator nerve passes down, and that's going to innervate the part of the upper inner thigh, okay, in the region of the groin. The final plexus then is the sacral plexus. The sacral plexus is going to have the innervation for the lower limb, the pelvic structures, the perineum, the buttock. This is, again, in the posterior aspect of the body. Okay. The largest of these is going to be the sciatic. The sciatic is actually the thickest and longest nerve in the entire body. It's really composed of two nerves, one called the tibial and one called the common fibular. If you take a look at the sciatic comes out through those sacral foramen. Remember, the sacrum are going to be fused vertebra as opposed to having the individual vertebra. So the sciatic is going to come out. It passes down the leg. It then splits into what's called the common fibula, which runs along the lateral aspect where we have the fibula. And then it runs straight down the back along the tibia all the way to the foot where we have the plantar branches. Okay. The sciatic nerve you mostly do not become aware of unless you get something called sciatica. Sciatica is where you have pain that can radiate all the way down the leg. It can feel like it's deep inside of your thigh, inside of your hip. Sciatica actually is really common in men, especially men who sit for long periods of time with a wallet in their back pocket. And the reason for that is when you are sitting, you basically sit on your sciatic nerve. If your gluteal muscles are very tight, they can press the sciatic nerve. The sciatic nerve sits in a little notch of bone called the sciatic notch. And if the muscles get really tight and press that sciatic nerve up against the sciatic notch, you can get sciatica, which is where you get pain, sometimes numbness, sometimes tingling, all the way down your leg, all the way down to your foot, okay, from that sciatic nerve. The reason it's common in men who put their wallet in their back pocket is when they sit, that wallet actually presses right, if you, in typical pants, presses right on to the sciatic nerve. Okay? And so that would be sciatica. So those are the different plexes that we see.